Hello, class. This is week 4. We will be discussing the pharmacology of local anesthetics and vasoconstrictors. The information for this PowerPoint lecture can be found in Malamed chapter 2, 3, and 4, and Havalis chapter 4 and 9. Now, as we discuss neurophysiology in week 3, you know that local anesthetics, when used for the management of pain, it differs from most other drugs commonly used in medicine and dentistry in one important manner. Virtually all other drugs, regardless of the route through which they are administered, they must ultimately enter the circulatory system in sufficiently high concentrations before they can exert a clinical action. But local anesthetics, when used for pain control, cease to provide a clinical effect when they are absorbed from the site of administration into the circulation. The one prime factor involved in the termination of action of local anesthetics used for pain control is their redistribution from the nerve fiber into the cardiovascular system. I think we discussed that in neurophysiology. So, the presence of local anesthetics in the circulatory system means the drug will be transported to every part of the body. So, local anesthetics have the ability to alter the function of some of these cells. So, let's get into this world of the pharmacology of local anesthetics and vasoconstrictors. The pharmacology of local anesthetics. The purpose of local anesthetics is to block the conduction in nerve axons of the peripheral nervous system. These are properties of the ideal local anesthetic: potent local anesthesia, absence of systemic and allergic reactions, good tissue penetration, long shelf life, reversible local anesthesia, rapid onset and good duration, low cost, ease of metabolism and excretion. This is the local anesthetic structure. There are 3 parts. You can see part 1 is the R, the aromatic nucleus. Part 2 is the linkage, either an ester or an amide. And number 3, the N, is the amino group. There are 2 major chemical groups of local anesthetic agents. There are 2 classifications that you need to know. They're either the amides or the esters. You can see that 4 examples of amides are lidocaine, mepivacaine, bupivacaine, and prilocaine. These contain 2 I's, so it's just a little trick to help you realize that these are amides. And then the other classification of local anesthetic agent is esters. Example, cocaine, benzocaine, pontocaine, novocaine. These ones only have 1 I. So let's talk about the amide local anesthetic agent. Now, the amide local anesthetic agents are usually parenterally. Their relatively lack of allergenicity and the primary site of metabolism is in the liver. Patients with lower than usual hepatic blood flow or poor liver function are unable to biotransform amide local anesthetics, and therefore may lead to increased anesthetic blood levels and a potential increase in toxicity. So, if your patient has significant liver dysfunction, the American anesthesiologist classification of 4 or 5, or heart failure, the American anesthesia classification of 4 or 5, represents contraindication to the amide local anesthetic drug. Primary excretory organs are the kidneys. So, the ASA classification is 1, 2, 3, 4, 5, and 6. 1 is normal, healthy patient. 2, mild to moderate systemic disease. 3, severe systemic disease that limits activity but is not incapacitating. 4, severe systemic disease that limits activity and is a constant threat to life. 5, patient not expected to survive 24 hours or without the operation. And 6, clinically dead person being maintained for harvesting of organs. Now, the second classification that we're going to talk about is the ester local anesthetic agents. They are used extensively before the introduction of the lidocaine or the amides. There's a higher incidence of allergy. The ester local anesthetics are hydrolyzed to PABA and diethylamine alcohol. PABA is toxic to testes, spleen, and liver. They are metabolized in the plasma by pseudocholinesterase, a plasma enzyme produced in the liver. Primary excretory organ are the kidneys. Now, clients that say that they are allergic to local anesthetics, is you have to investigate this a little bit further. Number one, it is highly unusual that they are allergic to local anesthetics. You need to dig a little deeper and ask them what happened. And most likely it is anxiety. There is a preservative in local anesthetic cartridges with epinephrine, sodium metabisulfate, and it is not the same as the sulfa allergy. Or they don't like the feeling they get after a previous injection, like increased heart rate, tremors, or dizziness. There are systemic actions of local anesthetics, and most are related to blood levels. So, for example, if you have higher blood levels, you're going to have a higher clinical action. So, local anesthetics, as we said before, they readily cross the blood-brain barrier and can cause central nervous system depression. For example, if you look at lidocaine, 0.5 micrograms per mil, there is no central nervous system effect on any clinical significance. If you have 0.5 to 4 micrograms per mil, it will produce anticonvulsive properties and can be used to terminate or decrease duration of both grand mal and petit mal seizures. More than 7.5 micrograms per mil, they can cause tonic-clonic convulsions. Now let's look at some of the systemic actions of the local anesthetics, in particular to the central nervous system. You're going to see that your patient, if they are having preconvulsive signs, they include slurred speech, muscular twitching, tremors of the muscles of the face, and distal extremities. So let's look at the systemic actions of local anesthetic to the central nervous system. There are preconvulsive symptoms that your patient may feel, which then may be central nervous system toxicity. and they will experience numbness of the tongue, warm, flushed feeling of the skin, pleasant dreamlike state, generalized lightheadedness, dizziness, inability to focus visually, auditory disturbances like tinnitus, drowsiness, and disorientation. The more severe central nervous system um, actions, systemic actions, would be the clonic seizures or the grand mal seizure, which involves both tonic, like the stiffening, and the clonic, with the twitching or jerking phase of the muscle activity. It may start with a simple partial seizure or aura, and the person may experience changes in sensation, mood, or emotions leading up to the seizure. If this is happening to your patient, do not put anything in their mouth, do not restrain them, and make sure that the area around the person is clear of objects that could injure them. People at higher risk have brain injuries related to a head trauma, infection, or stroke. This is just a pictorial representation of a generalized tonic-clonic seizures. So A is the tonic phase, B is the clonic phase, and C is the post-ictal confusional fatigue phase, where the body is limp and the limbs are limp. Clonic phase is when the clonic jerks of the limbs, body, and the head. And the tonic phase is when you get the stiffening of the body and limbs and the back is arched. Now, the other systemic action of local anesthetic, the first, as you remember, is the central nervous system. The second is the cardiovascular system, because local anesthetics have a direct action on the myocardium and the peripheral vasculature. So it will cause myocardial depression, which is decreased electrical excitability of the myocardium in the conduction rate and the force of the contraction. And in the peripheral vasculature, most of the local anesthetics produce peripheral vasodilation. So you'll get increased blood flow to and from the site of the local anesthetic deposition, therefore decreasing depth and duration of the local anesthetic. So when you have a lot of local anesthetic, you're going to get peripheral vasculature or vasodilation. So when you have vasodilation, it increases the size of the vessels, and so the local anesthetic will be less effective. There are pregnancy and nursing considerations with respect to the systemic action of local anesthetics. Elective treatment should be done before or after pregnancy. If the dental treatment is needed, a conservative dose of lidocaine may be used, and larger doses administered near term may result in fetal bradycardia, which means the increased heart rate of the baby. You should use lidocaine and prilocaine for the pregnancy category B, and you should use the mepivacaine, articaine, and bupivacaine in the category C. So the usual dose of local anesthetic can be given to nursing mothers with a healthy baby. Now, there are two words that you need to understand, and that is absolute contraindication and relative contraindication. Absolute contraindication means under no circumstances should the drug in question be administered to the patient because of the possibility of potential toxic or lethal reactions. Relative contraindications means that the drug in question can be administered to the patient after careful weighing of the risks associated with the use of the drug versus the benefit. So it's the benefit risk weighing it out to find the acceptable drug. If acceptable alternative drug is not available. This is a picture of all the different local anesthetics available in North America. Articaine, bupivacaine, lidocaine, mepivacaine, and prilocaine. And we will be talking about each one of these. There is a color coding system of local anesthetic cartridges. You are not expected to know the color of the cartridge bands, but you are expected to know that there is articaine. It can come with epinephrine, 1 in 100,000. There is bupivacaine with epinephrine, 1 in 200,000. There is lidocaine HCl 2% with epinephrine. So whatever local anesthetic you choose to use on your patient, you need to document this. So, for example, looking at lidocaine HCl 2% with epinephrine, 1 in 100,000, you need to write down how many cartridges, how much lidocaine, what part is HCl 2%, and you need to write down epinephrine 1 in 100,000, how much epinephrine you've used. Articaine. Let's talk about articaine first. Now, articaine HCl 4% comes with epinephrine 1 in 100,000. It is available in Canada, but there are reports of paresthesia, short to long-term numbness or altered sensation. Usually it affects the mandible, the IANB, primarily the lingual nerve, and it can get numbness of the tongue and lower lip for months or even years. Articaine has advantages. It diffuses well through bone. The maximum infiltration palatal, 90 to 95% is metabolized in the plasma before it reaches the liver, like an ester. And there is a presence of sulfur atom in the ring, which increases the lipophilic properties. So you get a fast, reliable infiltration of soft and hard tissues because of, as you remember, the membrane, if it is lipophilic, it will be able to, your local anesthetic will be able to cross that barrier quickly. Articaine has a short half-life, so nursing mothers, it is a good appeal to them. So let's talk about bupivacaine HCl. Bupivacaine HCl 0.5% with epinephrine 1 in 200,000. It is 4 times more potent than lidocaine, mepivacaine, and prilocaine, and it is primarily used in dentistry, not dental hygiene. It is primarily used for long dental appointments, extensive periodontal surgery, full mouth reconstruction, implant surgery, or used for the management of post-operative pain, like after a very long or difficult root canal treatment or periosurgery, implant surgery, or extraction. It is the anesthetic of choice for long durations of action with epinephrine. It is a post-op control medication because it provides 12 hours of relief. But the disadvantage is that it has a slow onset of action. So it is used as the second anesthetic in a piggyback setup. It is 4 times more toxic than lidocaine. So it has cardiovascular and central nervous system considerations. It is best used with patients with a history of drug use, And it usually what you would do is use lidocaine first with epinephrine because it has a very quick onset of action. Then you follow it up with bupivacaine. Bupivacaine is an amide type. Remember, two I's, so it is an amide type, category C drug. It is metabolized in the liver. It is excreted in the kidneys. The onset of action is slow. The half-life is 2.7 hours, and it is contraindicated in persons with known sensitivities to amide type long local anesthetics. Let's talk about lidocaine HCl. Lidocaine HCl 2% is not available in Canada. So you will find lidocaine HCl 2%, usually with epinephrine of 1 in 50,000, or lidocaine HCl 2% with epinephrine 1 in 100,000. In the clinic, you will be using the lidocaine HCl 2% with epinephrine 1 in 100,000. It was the first marketed amide type local anesthetic. It was quickly replaced by Novocaine as the local anesthetic of choice, and it is the gold standard. Every new local anesthetic is compared to lidocaine. Lidocaine, two I's, is an amide type local anesthetic. It is category B. It is safe after the first trimester. Metabolism is in the liver, excreted in the kidneys. Onset of action is very rapid, 3 to 5 minutes. Half-life is 1.6 hours. Allergy, it is contraindicated in persons with known sensitivity to amide type local anesthetics. Let's talk about mepivacaine HCl. Mepivacaine HCl 3% plain, which means it has no vasoconstriction constrictors like epinephrine and levonorepinephrine in it. Mepivacaine also comes with the vasoconstrictors in them. It has a milder vasodilating property. It is a milder vasodilating property of mepivacaine plain, and it provides a longer duration of anesthesia than most plain local anesthetics. So it is the LA of choice with people who are contraindicated for receiving vasopressor because of cardiac issues. So if your patient has cardiac issues or taking tricyclic antidepressants, for example, they will be using mepivacaine HCl 3% in the clinic. It is the most common among the GPs for treating pediatric and geriatric patients. Mepivacaine HCl is an amide type, metabolized in the liver, excreted in the kidney, rapid onset. It is contraindicated in persons with known sensitivity to amide type local anesthetics. Prilocaine HCl, 4%, or prilocaine HCl 4% with epinephrine 1 in 200,000. Now, with prilocaine, it is metabolized and it produces orthotoluidine, which can induce the formation of methemoglobin, which can lead to methemoglobinemia, a condition in which the iron in the hemoglobin molecule is defective, making it unable to carry oxygen effectively to the tissue. So it is obviously contraindicated in patients with idiopathic methemoglobinemia or congenital methemoglobinemia, people with sickle cell anemia, or people with cardiac or respiratory failure evidenced by hypoxia because the methemoglobin levels are increased, decreasing oxygen carrying capacity. Prilocaine, 2 eyes, is an amide type category B. It is metabolized in the liver, but a lesser degree in the kidney and lung. So it is good for liver dysfunction. It is excreted in the kidneys. Onset of action 3 to 5 minutes. It is contraindicated in persons known sensitive to amide type local anesthetics. The duration of local anesthetic. The factors affecting duration: number one, variations in the individual's response to the agent administered. 2, accuracy of administration. 3, condition of soft tissue. 4, anatomic variation. And 5, the type of injections, like blocks last longer than infiltrations. Medical, medical conditions with local anesthetic. Um, Medical conditions with local anesthetics: seizure, bronchial spasms, angina, and COPD. It is stress induced, but there are no contraindications. Heart failure, liver function, drugs staying in the body longer, bypass, stroke, heart attack, you need to consult the MD. Okay, other medical conditions with local anesthesia is heart murmur, which is okay, pacemaker, which is okay, hyperthyroidism. They're not to have epinephrine. So if your patient presents with hyperthyroidism, you need to use mepivine or another drug that's plain. Um, if your patient is using recreational drugs in the last 72 hours, no local anesthetic or treatment. If suspected, ask the client. Definitely offend the patient or kill them, because you can overdose on the LA. Methamphetamines can be a problem, but not likely to be in the office. Duration of anesthesia. Of course, every individual varies in their response to local anesthesia. Some people, they are quickly anesthetized, and others they are not quickly anesthetized, and it takes a longer time. So here is a curve. This is the normal distribution curve. Pulpal, of course, is always shorter in duration than soft tissue. And if you look at this figure, you'll find it in Malamed, page 59, figure 4.1. For example, lidocaine 2% with epinephrine 1 in 100,000. You'll get a pulpal anesthesia for 60 minutes, but soft tissue you get 3 to 5 hours. This is the normal distribution. If you look at this curve, it is the bell-shaped curve. So normally 70% respond appropriately, 15% hypo respond, and 15% hyper respond. This is very important because you will need to learn how to calculate concentration of local anesthetic. You need this for your board exams and all you'll need it for your midterm and your final. So let's look at this. You have 2% lidocaine with 1 in 100,000 epinephrine. The question is, how much lidocaine is in a cartridge? Now, you know that it is a fact that each cartridge contains 1.8 mils. 2% equals 2 grams over 100 mils, which is equal to 20 milligrams per mil. So to calculate this, 20 milligrams per mil, you multiply it by the amount in the cartridge, and you will get 36 milligrams of lidocaine per cartridge. So if you want to calculate concentration of local anesthetic, how many milligrams of lidocaine is in 11.67 cartridges? So method one is you take 20 milligrams per mil, you multiply it by how much is in the cartridge, 1.8 mils per cartridge, and you multiply it by 11.67 cartridges, and you will get 420.12 milligrams of lidocaine in 11.67 cartridges. An alternative way to do this is method two. You know how many milligrams per cartridge from the previous slide. So 11.67 cartridges. You multiply it by 36 milligrams per cartridge, and you will get 420.12 milligrams. These are maximum recommended dosages. They are in red because you need to memorize them. These need to be committed to memory. Lidocaine 2%, 7 milligrams per kilo up to 500 milligrams. Articaine 4%, 7 milligrams per kilo, no absolute maximum. Bupivacaine 0.5%, 2 milligrams per kilo up to 200 milligrams. Mepivacaine 3%, 2%, 6.6 milligrams per kg up to 400 milligrams, and prilocaine 4%, 8 milligrams per kg up to 600 milligrams. Okay, you need to know how to calculate the maximum recommended dose. There will be questions on calculating maximum recommended dosages on your quiz, on your midterm, and your final. Now, what is the maximum recommended dose for a person who is 60 kilograms using 2% lidocaine? So let's look at the calculations. Now, the question tells you it is a 60 kilogram person. So that's where you get 60 kilograms. You multiply it by 7 milligrams per kg. Now, you have memorized that lidocaine's maximum recommended dosage is 7 milligrams per kg. That is where you get that value from. It's equal to 420 milligrams multiplied by how many milligrams of lidocaine is in a cartridge. And 2 slides prior to this, you figured out that there is 36 milligrams of lidocaine in the cartridge. So when you multiply that out, it equals to 11.67 cartridges. You always round down to the nearest whole number when answering cartridges. So the answer is the maximum recommended dosage is 11 cartridges. If you have any questions about this, you need to look on page 61 and 62. Malamed has several examples of calculations of maximum dosages and number of cartridges. For example, box 4.2 on page 61, patient 22 years old, healthy, female, 50 kilograms. And it shows you how to calculate maximum dosages and number of cartridges. Okay, let's talk about local anesthetic pharmacodynamics. Okay, all clinically effective injectable local anesthetics are vasodilators. The degree of vasodilation ranges from significant, like procaine, to minimum, like prilocaine, mepivacaine, as well as with both the injection site and the individual patient response. So after you deposit the local anesthetic into the tissue, the blood vessels, arterioles, and capillaries primarily in the area dilate, and you get an increased perfusion at the site. When the blood vessels dilate, vasodilation, you're going to get a redistribution of the local anesthetic into the cardiovascular system. You're going to get higher plasma levels of local anesthetic with an increased risk of local toxicity. You're going to get a decrease both in depth and duration of anesthetic, and you're going to get increased bleeding at the site of treatment due to increased perfusion. Vasoconstrictors. So, vasoconstrictors are drugs that constrict the blood vessels and thereby control tissue perfusion. They are added to local anesthetic solutions to oppose the inherent vasodilatory action of the local anesthetics. Vasoconstrictors are important additions to local anesthetic solutions. Vasoconstrictors are added to local anesthetics. They are needed to oppose the vasodilation properties by, number one, they constrict the blood vessels and decrease the flow to the site of administration. Number two, they absorb the local anesthetic into the cardiovascular system and slow it down. Number three, it decreases the risk of local anesthetic toxicity because it slows it down, slows the movement of the local anesthetic, and number four, more local anesthetic diffuses into the nerve where it remains longer, and it increases the duration of action of the local anesthetic. And number five, it decreases the bleeding at the site of administration. Okay, vasoconstrictors are sympathomimetic drugs. They are stimulant compounds that mimic the effects of the transmitter substance of the sympathetic nervous system, like epinephrine is an example of a simple pathomimetic drug, so is norepinephrine. If they have a hydroxyl substitution of the aromatic ring, termed catechols, if they also have an amine group with an aliphatic chain, termed catecholamines, epinephrine and norepinephrine and dopamine are naturally occurring catecholamines. There you see isoprotenolol and levonorepinephrine and how it looks like the epinephrine. So you can see that this is norepinephrine and what it does, how it constricts, and you get vasoconstriction versus if you go lower, at the very bottom, that's vasodilation caused by local anesthetics. So there are three categories of sympathomimetics based on the mode of action. So vasoconstrictors, there are three types: the direct, the indirect, and the mixed. The direct exert action directly on the adrenergic nerve receptors. That's the epinephrine. Indirect act by releasing norepinephrine from adrenergic nerve terminals from their intraneural storage site, like methamphetamines and hydroxylamphetamines and amphetamines and tyramines. Mixed is a combination of both meteramino and ephedrine. What is epinephrine? Epinephrine is also called adrenaline and is both a hormone and a neurotransmitter. So, as a hormone, it's made and released by your adrenal glands. As a central nervous system neurotransmitter, it's a chemical messenger that helps transmit nerve signals across nerve endings to another nerve cell, muscle cell, or gland cell. It is made synthetically and is also obtained from the adrenal medulla. It acts directly on the alpha and beta adrenergic receptors, but mostly beta. It also has systemic effects, as we already talked about, on the myocardium by stimulating the beta receptors, causing cardiac output and heart rate increase. And the other systemic effect is vasculature, stimulation of the alpha receptors, which causes vasoconstriction. There are two types of adrenergic receptors: the alpha receptor, activation of receptors resulting in vasoconstriction, and the beta receptors, activation produces vasodilation, bronchodilation, cardiac stimulation. There are three types. Betas are found in the heart and small intestine, and they cause cardiac stimulation and renin release. Beta 2s are found in bronchi, vascular beds, and uterus. So you'll get relaxation of the bronchial muscles, relaxation of muscle walls of the blood vessels, and relaxation of the uterus. And beta 3s are found in brown and white adipose tissue and are responsible for lipolysis. Vasoconstrictor risks. Epinephrine is absorbed from the site, same as local anesthetic. Therefore, there is a potential for increased toxicity. The resting plasma epinephrine is doubled after you inject one carpule of 2% lidocaine, 1 in 100,000 epinephrine. It can occur several minutes to 30 minutes. Epinephrine plasma levels equivalent to those achieved during moderate to heavy exercise after LA injection. So you need to have caution if your client has cardiovascular and thyroid disease. Vasopressor cons. There is a potential for local anesthetic ischemia, which means the injection sites have a lack of blood supply and it turns white temporarily. It has systemic interactions, increased heart rate, anxiety, sweating, and concerns with beta blockers and tricyclic antidepressants. So, if your patient has a problem with beta blockers and is taking tricyclic antidepressants, you don't use epinephrine. Beta blockers. Beta blockers prevent stimulation of the adrenergic receptors responsible for increased cardiac action. So a lot of people who have hypertension or migraines are given beta blockers. A to M are safe, N to Z are non-selected and not safe. When the name ends in olol, example, propranolol, pindolol, timolol, nadolol. Beta blockers and vasoconstrictors. Vasoconstrictors may cause a serious elevation of blood pressure and reflex bradycardia in clients taking non-selective beta receptor blockers. This is a relative contraindication to the use of vasoconstrictors. So, if a patient is taking beta blockers for hypertension or thyroid. You need to minimize the dose of vasoconstrictor or use a plain anesthetic. If a vasoconstrictor is used, they do suggest that you monitor the blood pressure and pulse for 5 to 10 minutes after administration. So, we need to talk about tricyclic antidepressants. Tricyclic antidepressants are used for depression, sleep concerns, headache, premenstrual concerns. Clients on these meds are at a greater risk for developing dysrhythmias and epi administration. It is recommended that if your patient is taking tricyclic antidepressants, to use a very minimal dose of epinephrine or to use plain. The administration of synthetic epi is absolutely contraindicated in patients receiving tricyclic antidepressants. So, amitriptyline, clomipramine, imipramine, Elavil, anafranil, tofranil. So, if your patient is taking a tricyclic antidepressants, do not administer epinephrine. Drug interactions with local anesthetics. Tricyclic antidepressants may increase the cardiovascular effect of vasoconstrictors and increase blood pressure. This is the contraindication to the use of vasoconstrictors. Again, stressing, minimize the use of vasoconstrictors or use plain anesthetic. Drug interactions with local anesthetics. Opioid sedation and central nervous system or central CVS depressants. So if clients are sedated with opioids, morphine, mepipridine, fentanyl, it may have an increased risk of local anesthetic overdose, especially in children. So large doses of local anesthetics may cause increased depression of the central nervous system or the coronary vascular system in those taking central nervous system or coronary vascular system depressants, cardiovascular depressants. So these are relative contraindications to local anesthetic. Minimize the dose of local anesthetics administered to these patients. Vasopressor and cocaine. All right. So cocaine results in tachycardia and hypertension. So if you administer a vasoconstrictor intravascularly, there's going to be an increased risk of a cardiac event, including dysrhythmia, myocardial infarction, or cardiac arrest. So cocaine is a local anesthetic which increases the risk of toxic levels of local anesthetic and overdose. Clients using cocaine within the past 24 hours should not be administered local anesthetic. Vasoconstrictors and the adrenergic neuroblockers or antipsychotic drugs. If your patient is taking an antipsychotic drug or neuronal blocker, adrenergic neuronal blocker, this type of drug may exaggerate the effects of the vasoconstriction, resulting in increased blood pressure. So this is a contraindication to the use of vasoconstrictor. You need to minimize the dose of the vasoconstrictor or use plain anesthetics. So if your patient is telling you they are taking an antipsychotic drug and you need to do local anesthetic, you need to use mepivacaine, something plain and nothing with lidocaine, and epinephrine. The clinical applications of epinephrine. So there are a lot of contraindications to epinephrine, but there are a lot of clinical applications of epinephrine. It's excellent for managing acute allergic reactions. It is excellent for managing persistent bronchial spasm, people with asthma. It is excellent for management of cardiac arrest. So as a vasoconstrictor, it is excellent for a vasoconstrictor for hemostasis. It is excellent for a vasoconstrictor in LA to decrease the absorption into the vascular system. So as a vasoconstrictor in local anesthetic to increase duration of anesthesia, and it is excellent to produce dilation of the pupils. So it has for the eye doctor, right? So they can see to the back of your eye. But epinephrine has contraindications, which you need to know about. Patients with, again, and this is just a repeat of what we've already discussed in previous slides, patients with more significant cardiovascular disease, class 3 and 4 ASA, patients with non-cardiovascular diseases, thyroid dysfunction, diabetes, sulfite sensitivities, patients receiving MAO, enzyme breaking down neurotransmitters, inhibitors, tricyclic antidepressants, and phenylthiazine or antipsychotic drugs. All of these are contraindications to epinephrine, and you need to know this. Epinephrine contraindications. So if blood pressure is more than 200 milligrams of, if it's 200 over 115, do not use epinephrine. Uncontrolled thyroid, hyperthyroidism, severe cardiovascular disease, less than 6 months after a heart attack, less than 6 months after a cerebral vascular accident, daily episodes of angina pectoris or unstable angina, cardiac dysrhythmias, coronary artery bypass surgery less than 6 months ago, and patients who are undergoing general anesthesia with halogenated agents. So should you use epinephrine or should you not use epinephrine? Can clinically adequate pain control be provided for this patient without a vasoconstrictor in solution? Ask yourself, what is the potential negative effects of poor anesthesia on endogenous release of catecholamines, such as dopamine, epinephrine, adrenaline, norepinephrine in response to sudden unexpected pain? There is a physical status. So when stressed, you will release 40 times more than when you are in a relaxed state. Dilutions of vasoconstrictors, commonly referred to as a ratio. 1 in 1,000 equals 1 gram, or 1,000 milligrams of a drug is contained in 1,000 mils of solution. So to produce a 1 in 10,000 or 1 mil of a 1 in 1,000 solution is added to 9 mils of solvent, therefore producing 1 in 10,000, 0.1 milligrams per mil. So it can be written as 1 in 50,000 epinephrine equals 1 in 50,000 EPI. So 1 cartridge is so 1 mil of 1 in 1,000 solution is added to 9 mils of solvent, which is in the cartridge, and that is how you get 1 in 10,000, 0.1 milligrams per mil, or 100 micrograms per mil. Dilutions of vasoconstrictors. The least concentrated solution that produces effective pain control should be used. So if you have a 2% lidocaine, comes in 1 in 50 or 1 in 100,000 epi, use the least concentrated solution that will produce the pain control that you need. What is the concentration of epinephrine in a cartridge of local LA? So if you want to calculate 1 in 50,000 concentration, so 1 in 50,000 epinephrine in 1.8 mil cartridge. Every cartridge is 1.8 mils. It is equivalent to 1 gram or 1,000 milligrams of epinephrine in 50,000 mils of solution. So the calculation is 1,000 milligrams for every 50,000 mils of solution is equal to 0.02 milligrams per mil multiplied by 1.8 mils per cartridge, which is equal to 0.036 milligrams per cartridge or 36 micrograms per cartridge. So, recommended maximum dosages of epinephrine given by the American Society of Anesthesiologists. 5.5 cartridges of 1.50,000 or 36 micrograms of epinephrine per cartridge. 11 carts of 1 in 100,000, 18 micrograms of epi per cartridge. 22 cartridges of 1 in 200,000 or 9 micrograms per epi per cartridge. So you need to memorize the maximum dosages of epinephrine. You will find the table in Malamed. This needs to be committed to memory. All right, let's look at the maximum dosages of epinephrine. If a patient has ASA 3 or ASA 4, clinically significant cardiovascular disease. So 1 cartridge of 1 in 50,000 is 36 micrograms of epi per cart. 2 cartridges of 1 in 100,000 is 18 micrograms of epi per cart, and 4 cartridges of 1 in 200,000 is 9 micrograms of epi per cartridge. Again, this is the ASA patient status classification. So, selection of your vasopressor. There are several factors that you need to consider. Number 1 is the length of the dental procedure. Number 2 is the need for hemostasis during and after the procedure. 3, the requirement for post-operative pain control and the medical status of the patient. Let's talk about topical anesthetics. Why? Because you want the administration of the local anesthetic to be as least traumatic as possible. How? By putting topical anesthetics on which diffuse through the mucous membrane, so the same nerve blocking action as injected local anesthetic. Topical anesthetics, 18 to 20% benzocaine, lidocaine, tetrahydrochloride, diclonine hydrochloride, and cocaine hydrochloride. So if you can see those pictures there, most you will probably be using in your private practice. Up in the right hand corner, hurricane, benzocaine, and the lower left, Ceticaine, which is administered with a microdropper. And then you have the oral quicks, which is it looks like a needle, but it's not. It is a little cannula. Topical anesthetics, let's talk about them. You might ask, why don't we just put topical anesthetics over all the areas? It's less invasive, but it is effective only on the surface to a depth of 2 to 3 millimeters, and it must be applied for 1 to 2 minutes to be effective. It is available as a spray, but if the individual doses cannot be measured, don't use it. And they are higher in concentration than the same local anesthetic administered via injection to facilitate diffusion, and it is quickly absorbed because of vasodilating properties, and it increases the risk of toxicity. So benzocaine is an ester local anesthetic. It is insoluble in water. It is soluble in alcohol, propylene glycol, and other vehicles suitable for surface application. It is slowly absorbed into the cardiovascular system, so therefore is less likely to produce overdose. And concentrations vary from 50 to 200 milligrams per mil. That's hurricane versus oral gel. EMLAs, or eutectic mixtures, which are 2.5% lidocaine and 2.5% prilocaine, which is the oral kicks. It is applied into periodontal pockets with that tiny cannula, and it produces an effect in 30 seconds and it lasts 20 minutes. So you apply it to the gingival margin around the selected teeth and you wait 30 seconds. The applicator is inserted into the base. You can see the picture on the right lower right hand corner of how that is applied. So the applicator is inserted into the base of the pocket. It is filled until the gel becomes visible and kind of sort of overflows into the gingival margin. You wait 30 seconds and then you begin scaling. The maximum recommended dosage is 5 cartridges. Ceticaine or benzocaine, tetracaine, it remains a liquid, and you just need a small dose of 1 or 2 drops per pocket. Has a pliable plastic tip. Maximum recommended dosage 0.4 mils. Factors to consider when selecting a topical local anesthetic. Be aware of the concentration of local anesthetic in the topical gel. Use the lowest effective concentration. Use lidocaine if an ester allergy exists. And be aware of base form or water-soluble forms of lidocaine topical. Avoid use in injured areas and avoid spray to maintain control of the application. And that concludes our lecture. If you have any questions, please don't hesitate to email me or ask me in class. Thank you.